Okay, so welcome everyone on board. The topic which I thought to discuss today, because actually we are like since long time I was not taking any class, so I was just thinking that the best way to learn is to teach, and I was feeling as if I was feeling a little rusty. So I thought to restart this connection which I have with all of you guys. um, so, all of us deal with cancer. Okay. So, um today we will have around a short discussion that what are the general concerns if you just hear that you have a patient with a tumor, with a cancer, whether it is a benign one or it's not a cancer, it's not a malignant one, it's a benign one, okay, or if it is a malignant one, okay. So there are certain concerns which you should be thinking whenever you have such patients. So just a second, please. Okay, so usually the first thing which we think is whether just a second, please. Yes, whether the the tumor or cancer uh, is limited to certain area, or if it is spread. Okay, so spread maybe if it is only spread to the local area, so local extension. Then the second thing will be the lymph nodes, and the third thing will be distance metastasis. Okay, so this is the first thing we will be thinking. Then the another important point will be that what is the nature of tumor. Okay, is it because this is an important point and you should be thinking about it, that number of cancer they are secreting tumors. So, can anyone give an example of secreting tumor? Anyone, please?
Carcinoid syndrome, sir.
Very good. One of them will be carcinoid. What else? Something common. Yes, Farhan. What about thyroid? Parathyroid? No, sorry, pituitary. Okay. Then pheochromocytoma. Okay. So this is example of few of the cancers which secrete something which is creating other than this local or lymph nodes or metastasis, because there will be effects, physiological effects of those hormones or secretions. Okay. What else? What else things you should be thinking? Actually, there are certain things which are surgical classification. Like, for example, if it is breast uh, cancer, there is a BIRAD 1, BIRAD 2, something like that. I don't know much about it, but generally, whenever you hear that you have a cancer patient, and you have, because there will be two category of things. One will be the cancer surgery itself, or you have a operated or before operation any patient which has a history of malignancy. So you will be defining about the category. Okay, so few more words that about the local spread, like if it is with the location. More important thing for anesthetist is if it is involving or near any vascular structure. Okay, because if it is I will request you to mute your mic, please. Whose mic is on?
पापा अगर आपको खोलना है अगर आपको इसको खेलना है ना
This is a big distraction for me. Whose mic is unmute? Anyways, so if it is any vascular structure around, that is a significant thing you should be knowing. Of course, usually we are not in habit of looking at the CT scan or MRI. Even I am very weak in it, but I will suggest, if you are able to at least read the report about of the local spread, is there any vascular structure, or you can have a discussion with the surgeon that whether this cancer which you are dealing with has any vascular involvement. Okay. If we think about the lymph nodes, one of the important thing will be that if lymph nodes are engorged, or there is any involvement of the lymphatic. This is more true with the breast surgery. So it is preferable not to take any IV line on that side. It's better to take on the other non-operating side. Okay. So this is, and if you are thinking about metastasis, so metastasis more, if it is bone, maybe at some times this is the primary presentation of the cancer will be through bone pain. Okay. And um, Dr. Sajid, I request you to mute your mic, please. I'm distracted about it. Anyways, so bone pain. Then, if it is in liver, it may it may cause, according to the location, it can cause, if it is involving any vasculature which is doing congestion in the liver, it can cause even portal hypertension or things like that. So liver and lungs. Okay. So usually bone, lungs, liver, we are and brain also. Sometimes there are brain metastases. Okay. So you should be knowing what are the metastases. Because if, for example, if there is metastasis in the lungs, which is involving any bronchus, I humbly request Dr. Sajid, I will request you to mute your mic, please. Okay. So, for example, if it is in the lungs, it can create, it can cause some, for example, bleeding. Okay. So there may be this hemoptysis, or like you should be knowing, because it can cause some respiratory symptoms. So you should be knowing about these things. Okay, so a few more points about it, that whenever there is this cancer, there are certain things which you will be you should be thinking about it. Usually, there is a number of time there is weight loss. Okay, there is anemia. Okay, this is also, for example, if it is any area in which patient is this is creating problem in eating habits or drinking, like for example, if see esophagus, there will be significant or there is oral tumors, patient will not be able to take. So this will be causing nutritional deficiencies, anemia, weight loss, and everything. Okay. So this is another important point you should be knowing. There, according to the different tumors, there will be different sign symptoms of thyroid. Like as we when mentioned, that thyroid will be separate. Pheochromocytoma will be having separate picture. So you should be knowing about it. Then the treatment. If the patient is having any, like, mainly three, four types of treatment patient will be taking. Either it is chemotherapy, okay, it is radiotherapy, or the patient can have, you might see the patient is having palliative treatment, palliative care. Okay, the patient can have some stomas, more so with the abdominal area. There, if there is obstruction, so a patient may have some stomas, like ileostomy or colostomy or things like that. Okay, and if there is nutritional problem, patient can have some this gastrostomy tube. Okay, for the feeding. So you should be knowing that what will be the effect of chemotherapy. Actually, the chemotherapeutic agents actually, because cancer cell is actually the apoptotic, the process, the apoptosis mechanism is not working well. So the cancer cells have uncontrolled growth and everything. So whenever, whatever cancer medications, majority of them, they are cytotoxic. So they are killing the normal cell. So that's why the cells which will be, that's why you will see the patients having developing alopecia, the patient developing this myocardial depression. So actually, this is because of this cytotoxic effect. Similarly, there is bone marrow suppression. So cell lines will be disturbed. So there will be anemia. There will be cell counts will be reduced. So accordingly, there will be problems. So whenever any patient receiving chemotherapy, usually they have a baseline echo, and then they have a repeat echo after the finishing of the cycle. So if any patient coming to you, so you should be like you will be only listening. There is a patient coming for this cancer surgery. So you have to dig in uh, all these points. If the patient receive chemotherapy, you should be expecting, or you should have a baseline this cardiac status. Okay, and you might need to have echo, and there should be interval change should be monitored. That if the patient does not have any cardiac depression and after that it develop after, so not every patient develop actually. Clinically significant cardiac depression does not occur in all patients taking chemotherapy, but as anesthetist, you should be looking into it. You should be looking for anemia. You should be looking for any things like that. Okay. So similarly, radiotherapy can have a problem a number of places, but mainly the thing which will be concerned will be airway. Okay. If there is any cancer in which patient received radiotherapy involving the area, there will be distortion of the airway because of fibrosis, and so you can expect difficult airway. Okay. So similarly, the concerns related to stoma, the infections and everything will be there. Then another important aspect which you should be considering when you are dealing any patient with cancer is pain. Okay. So these patients at some times may be on opioid therapy, and maybe they have sort of addiction or dependence. Not, not using the word addiction. It is dependence, opioid dependent patient. Okay. So if any patient with such scenario, you have to consider opioid replacement. Because this patient will be needing more. So the baseline requirement you have to fulfill, and additional opioid or additional adjunct medications you need for breakthrough pain. So pain therapy is a very important thing. Even if you have, like for example, you might have a patient with the CA head of pancreas. And so one of the component for you to treat is the pain. Okay. So a number of times they are coming also for palliative care. They are coming for celiac plexus block or any neurolytic blocks. Neurolytic blocks for with like any neurolytic block or radiofrequency ablation or cryotherapies. So they are also coming for such things. Okay. So a very important point uh, which you should be thinking is with reference to uh, like uh, like pain management. Okay. So what else? Okay. So anyone wants to add or any question up till now? Yes. Uh, Another important point is that you have to discuss with the surgeon that in like some more points which you should be thinking a number of time. And this surgery is occurring, there is a concept of frozen section. They send frozen section, and then they check whether it is positive. If it is positive, then they go for further uh, extensive surgery. Okay. And this is one thing. Then another important point is that sometimes if you are giving blood transfusion is at times blood transfusion has some association with the recurrence, okay, of cancer.
Hello, Dr. Zishan. Assalamu
Yes,
alaikum.
yes.
Regarding morphine, what is your opinion regarding morphine for the pain management of the cancer patient? Because morphine promote the malignant biological behavior of non-small cell lung cancer through, the immunofluorescence, and it promote the carcinogenic effect. So, what is
Yes,
your opinion?
actually, that's the reason opioids. The people are going towards opioid-free anesthesia. So I am a big advocate of opioid-free anesthesia. But
Mm.
at sometimes there is no other option. So you just have to do risk
I think
versus.
opioid-free anesthesia is difficult. Opioid-sparing anesthesia, if we use word
Yes,
opioid-sparing anesthesia,
opioid-free or opioid
yeah,
sparing. You are right. You are absolutely right.
yeah. But
Okay.
what is the yani what yani is your opinion regarding usage of morphine for post-operative
Actually,
pain of
actually,
carcinogen
the
patient?
you are you're absolute. That's what I told you, that you have to see the situation. It cannot
Mm,
be a generalized approach. Of course, you will have to follow the WHO step ladder. Okay. You
mm,
if it is possible to avoid or have some reduction, but practically, I don't think so. Such patient with extensive surgery might be you can have regional anesthesia. Okay. So
mhm,
wherever regional anesthesia is possible, you can you can use it. You can have, like, for example, hypex surgery. They keep
mhm,
hypex surgery is actually hyperthermic intraperitoneal chemotherapy. It is also called as cytoreductive surgery. It is used for a number of abdominal and pelvic cancers, not only for gastrointestinal in origin, also this ovarian carcinomas and everything. So actually, this is a very painful procedure. So a number of times they put epidurals, even, and they tunnel it. Okay, epidural catheters, and they tunnel it. So in these patients, there will be reduction in requirement of morphine. Okay. So at some time, unfortunately, there is no replacement for opiates. This is the problem. So it will be very difficult to control the pain. Yes, of course, wherever regional anesthesia is possible, even through our central nuclear block or nerve blocks, compartment blocks, or even wound catheters. So it will
mm,
reduce the requirement. But of course, your point is absolutely valid. That is the one of the reason of using the medications which can have opioid sparing effect, like gabapentin, like dexmedetomidine, even you can use IV lidocaine. Like, there are so many ways to control uh, pain, but unfortunately, it's not widely uh, popular. Plus, you need monitoring. This is
mm,
one of the reason of still the people dependent on. Actually, it's not only patient dependence; it is also the whole paramedical staff dependence on opioids as well. This is another reason, actually, because like, if you are trying to use IV lidocaine post-operatively, it will be challenging, because you have to look for signs of toxicity. You have to follow, if there is no other problem with the metabolism of lidocaine, you can use. Actually, I have not you because in now, that in Saudi Arabia we are not doing the post-op ICU. So I'm not sure,
mm.
is there any acceptability of this IV lidocaine in post-operative period. So if you are using IV lidocaine infusion, yes, you don't sometimes you don't need morphine later. Okay.
Mhm. And if you have remifentanil, we can use intraoperative, and
Rami,
post-operative we can.
the problem with remifentanil is you don't
Yeah,
tell
I know. Yani, if we,
the
stop, a
hyperalgesia.
patient is having severe pain, yes,
Yeah.
hyperalgesia. But,
Actually,
if we use, actually, the pain management of the cancer patient is very difficult. Yani, my question is pain management. Yani,
yes,
we are anesthetists, okay? And we are dealing with the pain management of pain management is sometimes challenging. Sometimes you are using 300 mics fentanyl with thoracic epidural, with morphine, with ketorolac, with acetaminophen, with lidocaine, with max sulfate, but patient is still having pain in the PACO.
yes, you
So
are.
yeah, so my opinion is if we have Altiva like remifentanil infusion intraoperative,
Mm,
and we will use the opioid sparing anesthesia like regional blocks. Like
mm.
if patient is having surgery on the upper abdomen, we can give this one, the PEX block, or erector spiny block. So block will help. But any pain
Actually,
management of cancer patient, because in cancer patient already pain receptors are hyperactivated. So there are
yes,
continuous firing of stroms. So a challenge is practical aspect. Number one is nutritional deficiency. Number two is anemia, pain management, and sometimes pain management is very, very not only difficult, challenging also. And if
yes,
we keep this thoracic epidural more than 5 days, there is chances of sometimes we encounter the patient is having infection. And in cancer patient, one of the most important things, fever. We think it is due to sepsis, but no, it is not due to sepsis. It is body's natural mechanism, and we aggressively treat. So uh, for me, because we are dealing with this, and I have a practical, scenarios that if we use multimodal approach for all patients, and I am totally against of opioid sparing, opioid free anesthesia, because we have many options. Like we have fentanyl, we have morphine. We can titrate according to the patient need, and according to the yani, tachycardia is not only sign of pain. We will apply the standard monitoring, like this monitoring, like we will apply the train of four monitoring for the neuromuscular blocker. If we give
mm,
a standard anesthesia, the pain management of the patient is multifactorial. It not only some tumors are very painful, you have to give yani more, because there is catecholamine surge and there is continuous firing. So pain management is challenging. And number two, anemia. And number three, nowadays, they are using anti-cancer therapy before, and also the drug induced also, like the bleomycin and the all anti-tumor drugs we are using for the cancer patient. They have a specific cardiorespiratory problem, like pulmonary fibrosis and cardiomyopathies and this thing. So it is multidisciplinary approach. Like if
sure.
tumor is gynecological, we have to talk with the gynecological urologist, medicine, physiotherapist. And if they notice, if patient come early and they will start ERAS protocol for cancer patient, definitely they are well managed, and their survival rates are apart from this, there is nowadays HIPEC surgery and cytoreductive surgeries. Uh, these surgeries are also challenging because of these fluids and prolonged surgery, and sometimes a continuous leakage of body protein. It will cause anemia. So albumin is one of the most important in management of the cancer patient. Uh,
You're
Thank you,
you're
Dr.
absolutely
Zishan.
Thank you. Actually, I will just add on to what you were saying. Actually, intraoperatively, pain management maybe have a lot of options, but more challenging things will be post-operative. Okay, so even if you have given a single short compartment block, it will not. There is no guarantee for how much time it will last. This is one thing. So that's why you will have to make an individualized approach. It depends on how was the manipulation, how extensive was the surgery, other risk factors. Okay, so you can use a number of options, which I have just chalked it right now. So you can use lidocaine, dexmedetomidine, even ketamine. Okay, and then regional blocks, different types of regional blocks, central nerve cell block, even spinal catheters are not in our setup, but a number of places in the world they are using intrathecal opioids for post-operative pain as well. Okay, so there are so many ways to control various according to the various patient groups, various surgeries, and extent of the surgery. So yes, as I was mentioning, that pain management is a challenging thing. Then one more thing, that usually blood transfusion is also one of the factor which can trigger reoccurrence. So actually, a number of times they avoid a blood transfusion until it is really necessary. Then again, there is use of cell saver. Okay, a number of surgeries, when they are using cell savers, there are special filters, but still there is some doubt about the recurrence of the malignancy. So I'm not sure whether it is 100% safe to use cell saver in cancer patients. So like purpose of this discussion today was just give you an idea that whenever you are dealing any patients with cancer, so you should be looking at the local extension, any vascular involvement, then the lymph nodes, and then the metastasis. You should be thinking whether the patient has any treatment, whether the surgery which you are dealing with is palliative, or it's sometimes they are just doing for as a palliative care, not as a definitive treatment. Okay, so the discussion with the surgeon is very important. Reviewing all the details of the patient is very important, because if you don't have a clear idea about this patient, the word cancer surgery actually, or any procedure name is misdirected, because you can miss a lot of things if you don't evaluate the whole all of the aspects of that patient. Okay, so thank you very much, all of you, for your precious time. Any questions? Any other thing anyone wants to add? Rest of the things will be same. So chemotherapy, radiotherapy, and meeting summary. You can change.
Nowadays, they are using a novel drugs for the management of the cancer patients.
Hmm.
Especially, and it is discussed a couple of weeks ago in our department that one of our colleague, told us about the novel treatment, and
What is
his
that?
novel treatments with. There are drugs. There are I forget the name of drugs. There are a list of drugs when they
Hmm.
use for the specific cancer. It will not only reduce the malignancy, but it will slow down the progression of the tumor. So they are also using, because sometimes surgery is any cut is not the any ultimate solution of the patient. Like suppose patient is 85 years old and is having malignancy. So in these kind of patient, if the patient is come across with the surgery, it will end up with the high mortality and high morbidity rates. So they are using specific drugs. There are a list of drugs, I forget the name, but they are using. And especially in the US, people are going there. They will, go through this anti-cancer drugs. There is, few uh, uh, what we call a few drugs. It will reduce the
Okay.
progression of.
Okay, so actually, a few things I was just missing. Psychological support is also very important. Rehabilitative services. A number of times after cancer surgery, sometimes actually rehabilitative medicine is a separate field of medicine. It has also not only pain, palliative care, and sort of like physiotherapy. So like bringing the patient back to the normal routine as early as possible, and as we because ERAS is future enhanced recovery after surgery protocol. So they are using the ERAS protocol in a number of surgery, like, so of course our discussion is not in detail for all specific surgeries, but I have just given you an idea that whenever you are having any cancer patient, look for vascular involvement, look for metastasis, look for staging, look for status of the patient overall, how bad the cancer is. So that will help you in overall management of the patient. Okay. So thank you very much. We will have I will try to continue our routine because I was feeling rusty. So, because what message I want to give all of you, that the day of your life, when you wake up in the morning, the day of your life, when you wake up in the morning and then you finish the day and you sleep, and you don't teach something you know and the other does not know, or learn something which you don't know before, that day of your life you wasted. So I want to spread this
Plus,
message to you. Either you teach
plus
or you learn.
anticoagulation,
Yes.
plus Dr. Zishan, thank you very
Yes,
much.
yes, yes. Very
Plus,
important. I missed this thing.
anti-
Thank you for. So
anticoagulation is
it's a
very, very important in cancer
pro
patient.
it's a procoagulant state. Okay. So anticoagulation is very important. Thank you for reminding. I had forgotten. Okay. Anything else,
Yeah.
Zulkarnain? Anything else I missed?
No, sir.
Okay, so thank you very much.
Mhm.
We will try to continue some of more tumors. Like, let's see what happens. According to my availability, I will just try to have some individual cancers. Okay, so thank you very much. We will meet again, inshallah. Salam.
Thank you very much.
Walaikum assalam.
Amin.